Bismillahirrahmanirrahim. Today, I will discuss maternal medicine module and I'm going to start with the domains. Including communication with patient and the families. And here, we will notice that the effects of the pregnancy on the pre-existing medical condition and vice versa came in both domains, communication with patient and the families and patient safety, but from different points of view. In communication, you have to do appropriate counseling without terrifying the patient. It should be clear without terrifying the patient. From point of view of the safety, it is appropriate understanding. So you should understand the effect. It should be right. In addition, some topics can come under the maternal medicine module, including the domestic violence, drug and alcohol abuse, child protection, FGM. In communication with the colleagues, in addition to the general points which come in every module, like being a clear, logical approach, making differential diagnosis, you have to give the appropriate amount of information which will help, or details which help your colleagues to understand your plan. And you have to know who are your colleagues. Usually MDT will be a failure point in every station and you need to know them. They mentioned here, specified the nurse specialists, physicians, psychiatrists, of course, when it is applicable, but in general, MDT is a failure point in all cases of maternal medicine module. In information gathering, you have to take relevant history, which is antenatal history, because this patient is pregnant, whether seeking for pregnancy, preconceptional, antenatal, labor, delivery, and it is the obstetric history. Your plan should be clear, and in the safety, in addition to the effects of the pregnancy on maternal medicine condition and vice versa, you have to remember the safety of medications and investigations. For example, if you will arrange for MRI, for CT scanning, for X-ray, whether it should be safe for the pregnancy or no. Medication review is a must in maternal medicine to pass the safety domain. So 2 points here for safety domain to pass. Review medications and the effects of the pregnancy on the medical condition and vice versa. In the applied knowledge domain, you have to give her the plan, whether preconceptional, antenatal, and postnatal. You have to understand the pathophysiology of the maternal disease, whether, for example, hypertension, asthma, and so on. Like in any other module, we could have simulated patient task or structured discussion stations. The template for structured discussion in maternal medicine module, we have to assess disease severity and then categorize her condition into high risk and low risk. Take full obstetric history, and this should include the history of the both current and previous pregnancies. Review her medications and see what we need to continue and what we need to discontinue. We need to examine the patient and give her information about the effects of the pregnancy on her medical condition and vice versa. Plan of care, including both preconceptional care, antenatal care, and postnatal care, and educate the patient, and this differ according to the disease. How, for example, in bronchial asthma, how to avoid the triggers of asthma, in sickle cell disease, how to avoid the trigger for the sickle cell crisis. In the plan of antenatal care, usually MDT, frequent visits will be failure points, and we have to screen the patient 4 different conditions which can happen during the pregnancy. For example, preeclamptic toxemia, anemia. Coming to the template for the simulated patient task, we have to start by assessment of disease severity. Open question like, can you tell me more about your condition? Then close the questions like the duration, for how long have you been diagnosed with this condition, how it was diagnosed, currently any problem, and the current problem depend upon the system. It varies between cardiac, renal, asthma. Last follow-up and visit with her specialist. Review her medication. It is safety point and usually considered like a failure point. So if the medication need to be discontinued, we have to tell her, and if we have to continue or start a new medication, we have to prescribe for her. And if you don't know whether this medication is safe or no, you can consult the local drug information service, or the pharmacist, the physician, or talk to your senior, and you can also take the opinion from her specialist. And in obstetric history, you have to cover current pregnancy, previous pregnancy. Don't forget, never forget folic acid, especially if in early pregnancy module. It could be usually in some early pregnancy module. In some cases, it could be like a borderline point. Infertility module also could be borderline, particularly if the patient is high BMI. And also anomalies, intrauterine fetal death. So some stations you will find folic acid like borderline point in information gathering. Coming to the gynae history. Gynae history is not essential if the patient is pregnant already, maybe last period only. However, if it is preconceptional counseling station, it should be asked in details because you evaluate her fertility by asking about the last period, the method of contraception, because if the patient not ready for the pregnancy, she needs to continue on the contraceptive method. Smear history also is important, like a preparation for pregnancy. Family history and partner history, if it is a genetic condition, is important. And support smoking, alcohol, and drugs. BMI is a must. You need to know the BMI of every patient early in the station, because if the patient is obese, many questions will be added. Many precautions will be taken during her antenatal care. So please, if the BMI is not specified outside in the scenario, you should know that there is a trick in the scenario and this patient could be obese. Psychological, because usually chronic conditions is distressing to the patient and she may be so much affected to the extent you have to offer her counselor, but counselor here is not the rule. Take care, because sometimes you will be deducted and they take borderline because of when you ask about counselor and if it is not indicated. So usually the rule is, if the patient have physical condition, don't offer counseling. If the patient have something in her psychological well-being, you can offer the counselor. Examination, usually no examination is required in role player stations. Don't waste your time, please. And if you want to examine, you have to justify, and then you have to tell her, we will examine you later, or you need to be examined for this and this. But you are not going to examine her right now, please, because you are mimicking like she is in true situation, and you cannot take your simulated role player and examine her in like a true situation. Investigations, usually they may give you investigation in the scenario, so you have to interpret whether they give you results of booking bloods, ultrasound scan, MRI. Interpretation is a must. It is a part of information gathering domain. And if you didn't find recent evaluation, for example, for the kidney condition in a patient and this patient is pregnant already, usually the evaluation of the kidney or kidney function test or this organ function will be should be arranged urgently or as soon as possible, because you have to categorize your patient into high risk or low risk according to the result of the organ function test and her affection. Now coming to the counseling. Counseling in maternal medicine module could be preconceptional counseling, antenatal, labor, delivery module, could be post-delivery. Extent of details depend upon the station you have in the exam. Now, after you gathered information from the patient, reviewed her history, examination, you will reach conclusion about whether this patient is high risk or low risk, about whether in the preconceptional counseling, if pregnancy is not safe, you have to explain to her that going into pregnancy now is not safe, and you have to justify by telling her, for example, according to the station, you have to start folic acid and justify, or to be reviewed by your specialist to review your medications, so change or stop the teratogenic medications, to optimize your health, to stop smoking, to lose weight, and you have to tell her that we postpone the pregnancy in order to optimize her health and reduce the risk of having complications in the pregnancy. Then, implications. You have to explain the implications of the pregnancy, whether preconceptional, antenatal. The patient needs to know the implications of the condition of her pregnancy and vice versa. So how disease affect pregnancy? If you usually the patient could be low risk patient, so reassurance is a must. It will be in the communication with the patient, with the lay examiner, and also could be with the clinical examiner. So usually the word "I can reassure you," usually use it more frequent if you are going to find the patient is if you found the patient low risk. So reassure her that most women with your condition will have healthy baby and healthy pregnancy, and you started to explain effect of the disease on the pregnancy trimester wise. If you can mention how to reduce this implication at the same time, it will be better. If you can't, you can just give her the implications. You can write implications in the 2 minutes outside the cubicle in your paper, so it will be easier for you to tell her the implication. Regarding way of communication here, it should be empathetic and not terrifying to the patient. And usually the implication, which is common for nearly all the diseases, is miscarriage, abnormal development, low birth weight, having the baby early before the due date, baby could die in the womb. If it is a genetic condition, you can tell her the risk of the condition can go to the baby or no, and how much is the risk. Then, how pregnancy can affect her disease. For example, in kidney disease, if her kidney condition is going to deteriorate, or most probably it will stay stable with follow-up and monitoring. Most candidates forget this point during their counseling, and most of the station, particularly in the stations, particularly in early pregnancy module, when the patient discovers that she is pregnant, main concern of the patient usually how the pregnancy can affect her kidney or her heart. Some women, if she discovers that her heart is going to deteriorate, she may request termination. That's why effect of the pregnancy on the disease in early pregnancy module is a must to pass the station. Then you will explain to her the antenatal care. Step by step, trimester wise, start by MDT, enumerate them, differ according to the system. For example, in cardiac patient, it could be it should include the cardiac specialist nurse, and should include the consultant, specialist midwife. Sometimes you need to involve the dietitian. Anesthetist could be involved also during the labor care, and the pediatrician also during the labor. More frequent visits and the justification to keep eye on her and her baby by more scans. We have to mention, usually in the maternal medicine module, they will not deduct you for the routine care, like the dating scan, except it is too relevant to the case, or the 20-week scan, except if the baby is at risk of structural problem in the system of the baby, and 22 cardiac scan could be important in cardiac patients, or if the patient is on medication which can affect the heart of the baby, then regular growth scans, plus or minus, aspirin. So we'll take it like trimester wise. Start from first trimester, mention about the folic acid, which could be higher dose, 5 milligram if the patient is obese, diabetic, epileptic, and other indications. 12-week scan and Down syndrome screening. Then start aspirin at 12 weeks if there is risk of growth restriction, preeclampsia. 20-week scan and 22 scan for the heart, plus or minus regular growth scans if indicated, and the OGTT is a routine. But sometimes it is a must to be mentioned. For example, if the patient is on a medication which can lead to diabetes, if she's obese, or if she has previous history of strong family history of diabetes, then tell her about the risk of having the baby early. If the patient is indicated for induction, you have to tell her about the plan for induction of labor, the timing of the delivery which is indicated. For example, in sickle cell disease, we need to deliver patient at 38. Also in diabetes, we have to induce labor in diabetic patients. So, plus or minus, because most of conditions, the patient can go into spontaneous delivery. So the plan for delivery should be discussed during the antenatal period, and medication review is a must. And in addition to the medications specific for the condition, we have additional medications like aspirin, low molecular weight heparin, prophylaxis, VTE risk assessment. VTE risk assessment should be done in all stations, whether in all antenatal, early pregnancy, labor, delivery, postnatal, should be done. And the warning symptoms and the signs could be applicable. And ask her if she has any specific plans for labor. Labor, usually we discuss the plan. Sometimes, most of the stations with the consultant at 36 weeks, but sometimes we need to discuss it early at 32 weeks, for example, in severe mental illness or severe cardiac disease, severe renal disease, because most of patients will need induction, or they may go into preterm delivery. So she will have her plan ready in her notes in case she came early in labor. And the multidisciplinary team will continue the care. The delivery should be at hospital with the under consultant, and term delivery. The mood should be discussed. Usually our aim is for vaginal delivery, spontaneous one. Cesarean section will be for obstetric indications only. Patient autonomy should be respected regarding the timing, regarding the place and the mood. But the timing, usually we do not agree for her request if she requested early delivery, because you know the risks of prematurity, and we have separate stations where we do negotiation with the patient regarding the timing and the place and the mood of the delivery. So for the mood and the place we can agree, but the timing we can't agree. Medication should be reviewed. She should continue her medications. And we have medications which can be taken and medications which should be avoided, like methergine, ergometrine, and any medication depend upon the system. For example, in bronchial asthma, we have some medication should be avoided because it can lead to bronchospasm. Monitoring, usually by maternal observation, and CTG is a must. And in most of the stations, it will be borderline point. And avoiding triggers of the condition. For example, in asthma, triggers, sickle cell triggers. The extent of detail of labor will not be required, depend upon the stage of the pregnancy, the trimester. In the preconceptional and early pregnancy, the detailed care during labor will not be required. And in order to know if the patient wants something to know about labor, you can ask her, would you like me to explain to you about the labor? Maybe she will have a concern about water birth, about back needle, and you can expect that according to the case. For example, in thrombocytopenia, patient usually ask about the back needle. So you can expect what is the concern during labor. In epilepsy, for example, the patient will ask you about the water birth, or should I have fed during labor? Where can I deliver? Can I go into labor alone, or you have to give me some medication? So according to the station, you can predict what could be the concerns for the labor, but usually will not be required in details. But if the patient, if the station is in labor and the delivery module, of course, every detail should be mentioned during the labor care. Following delivery, multidisciplinary team will continue her care. The patient place of care should be mentioned. Sometimes it will be in the postnatal ward, sometimes could be in the special care, for example, in cardiac patient. And patient monitoring should be mentioned, for example, repeating blood tests, giving her frequent measurement for her blood pressure in cases of preeclampsia and chronic hypertension. Before she go home, contraception should be discussed, and breastfeeding, whether she can breastfeed the baby, whether her medications are safe for breastfeeding or no, and when she can go home, and the follow-up appointment, and the baby care by baby doctor. Sometimes baby will, you have to mention to her the heel break test, because they do it routinely for all babies for certain conditions, and like cystic fibrosis and imaging. Sometimes you have to do imaging for the baby if there is risk of intracranial hemorrhage, for example, in severe type of von Willebrand type 3. So it depends upon the station. At the end of your station, you have to summarize, and summary is important, particularly if you have lay examiner. It is part of his safety domain. Next step, and if you have to refer her, for example, the specialist, if she hadn't visited her specialist since a long time, you have to refer her, and referral should be as soon as possible if the patient is pregnant and have not been evaluated recently. So the referral should be urgent or as soon as possible, and be careful with this word, because usually they deduct because only some words like urgent, as soon as possible. But in preconceptional, no, it shouldn't be urgent, because patient not pregnant, no urgency in the situation. Consultant involvement, so you can tell her, and my consultant I will give you an appointment, particularly if in the start of the station they mentioned the patient was supposed to meet your consultant and your consultant is busy, for example. So you have to arrange an appointment for her with the consultant. You can mention this in the summary. And if the letter came from the GP is waiting for you, or you reply, or you need to involve the GP in something. I saw it only in one station where they deduct because not writing back to the GP, but because the GP has certain job to do. And for example, he will do the referral to psychiatrist. He will manage the asthma, the bronchial asthma, or These are the best examples. Then you could be deducted if you didn't involve him or write back to him. Sometimes the letter will be from community nurse or community midwife. So you have to write back to her. Depend upon the station. And you have to give her contact number